Good morning, dear colleagues. Today I would like to present to you the case of suspected duodenal atresia. We are talking about a rare and non-syndromic intestinal malformation characterized by a complete obliteration of a short segment of the duodenal lumen. It has a prevalence in Europe of approximately 1 in 11,000, with no significant differences observed between males and females. The exact etiology is currently unknown, but it is hypothesized to be closely related to vascular anomalies, neural cell migration defects, and the failure of duodenal lumen recanalization. One particularly significant diagnostic finding for this condition is the double bubble sign, which is caused by the significant overdistension of the stomach and the first proximal portion of the duodenum. In order to accurately suspect this condition, it is absolutely essential to observe that the two bubbles corresponding to the stomach and the proximal portion of the duodenum are seen to communicate with each other. This step is also critically important to rule out certain differential diagnoses, such as a mesenteric cyst or a choledochal cyst, for example. Under normal circumstances, the clinical suspicion of a condition like duodenal atresia typically arises during the period between the 24th and 26th week of gestation. However, in this specific medical case, we are currently dealing with a pregnant woman who first came to our facility at the 21st week of her gestation, and as a direct result of this early visit, a much earlier diagnosis was successfully made by our team. It is crucial to keep in mind that this diagnosis is considered to be always and only a clinical suspicion, because only at birth can the pediatric surgeon definitively confirm the diagnosis of duodenal atresia. This is different from other diagnoses that must be ruled out, such as, for example, annular pancreas. Another important aspect to consider, besides verifying that there is communication between the two bubbles, is to exclude the possibility of any association with specific underlying syndromes. In fact, duodenal atresia is associated in 1/3 of cases, which is about 30%, with the chromosomal condition known as trisomy 21. In 20 to 25% of cases, it is associated with congenital cardiac defects, that is to say, heart diseases. And in 10 to 20% of cases, other defects are also found, including not only cardiac issues but also renal and vertebral malformations. Even though the pregnant woman had already undergone a fetal DNA screening test, which indicated a low risk for Down syndrome, we still carefully searched for and successfully ruled out any signs indicative of this condition. First of all, brachycephalic head was excluded, which in this case is absent, with a cephalic index within the normal range. Then, careful attention was also given to the fetal profile, ruling out the presence of nasal hypoplasia and a flat facial profile. Next, the nuchal fold was examined, which in our fetus under examination was found to be within the normal range. Since, as we have previously mentioned, in approximately 20 to 25% of all cases, duodenal atresia can be associated with congenital heart diseases, a thorough and detailed study of the fetal heart was performed, which in this specific case was found to be completely normal. Nevertheless, it is still important to provide information to the couple about the essential requirement to schedule a fetal echocardiography, specifically during the period between the 27th and 28th week of gestation. The last sign we evaluated, as it is indicative of Down syndrome, is the length of the long bones, particularly the femur and humerus. In the presence of the syndrome, in fact, these bones may be shorter. In the fetus under examination, however, the long bones are adequate and actually slightly longer than expected for the gestational age. However, what was actually discovered in this particular case instead was the presence of mild polyhydramnios, showing an amniotic fluid index of 22 centimeters. Polyhydramnios is actually a very common and typical clinical finding in cases of suspected duodenal atresia, and it is known to occur in approximately 50% of all cases, following the 24th week of gestation. However, in this specific case that we are currently observing, it is already clearly present at only 21 weeks. It is essential to provide comprehensive information to the couple through appropriate multidisciplinary counseling about the necessary steps and procedures that should be followed. That is, a detailed genetic consultation during which the geneticist must explain the various risks and benefits of possibly performing an amniocentesis with fetal karyotyping. and a specialized surgical consultation, considering that this is a specific medical condition which, if treated promptly with surgery, has a truly excellent prognosis. Finally, a consultation with a neonatology specialist is also considered absolutely necessary because, given the increased risk of preterm birth associated with polyhydramnios, it is highly recommended to advise the couple to plan the delivery in a specialized medical facility that is fully equipped with a neonatal intensive care unit.